I request Dr. Malleswari to deliver her talk on steroid-induced glaucoma, the extent it goes.
Good morning, one and all. So, steroid-induced glaucoma we all encounter in our day-to-day life. So, first of all, thanks to APYs and thanks to GRD sir for giving us this opportunity. And this steroid-induced glaucoma, like we all do cataract surgery and we need to keep steroids for 4 to 6 weeks depending on the cataract. And so, we all encounter this steroid-induced glaucoma. So, the steroid responsiveness we can see in almost all patients. Sometimes it will be around less than 6 millimeters of mercury, sometimes it will be between 6 to 15 millimeters of mercury, sometimes it is more than 50 millimeters of mercury from the baseline. So, most of the patients they used to have this low responsiveness, and some patients they used to have this moderate responsiveness, that is between 6 to 50 millimeters of mercury. So these patients, they are not having much problem, just giving anti-glaucoma medications is fine. And the next group is the high responders, where the intraocular pressure is more than 15 mmHg from the baseline, or it may be more than 32 millimeters of mercury. So these patients usually encounter problems, they need medical therapy, they need surgical therapy. So all these patients, so they do need therapy in case of high responders. And when it will happen acutely or it will happen in weeks to months period. So if acute phase we will encounter in case of depot steroids like intravitreal triamcinolone, or if the patient is on high potent topical as well as systemic steroids. But the most commonly we used to see after 3 weeks or after 4 weeks of taking steroid therapy. So which age groups are affected? So all age groups are affected, but most commonly the children less than 6 years or the older folks are more commonly affected. And the presentation is most of the times it's asymptomatic, and sometimes if the patient pressure goes to 40 or 50, when the corneal edema develops, they used to feel of blurring of vision. So always the prevention is better than cure. So always the physician should aware that the patient underlying conditions and then counsel the patients. And if the patient is a child, you need to counsel the parents very thoroughly. And before starting any steroid treatment, the physician should take a call to counsel the patient and should take the history of all these things like primary open angle glaucoma in the family, or younger children, or high myopia, or uncontrolled diabetes or hypertension, rheumatoid arthritis, or previous history of steroid responsiveness, or Fuchs disease. These things we need to take into consideration before starting steroid. So once the patient develops steroid responsiveness, first thing is we need to stop the steroid. If we can't able to stop the steroid, at least we need to come down to the low dose therapy, and then you need to start the glaucoma management with the medical management. Then if it is not controlled, you can go for surgical treatment. But if the intraocular pressure is not reduced even with the medical management, if it is a depot steroid like intravitreal, you need to excise that one by doing vitrectomy. And the steroid, like I already said, if it is definitely needs steroid, you need to come down to the low dose steroid. And if it is less than 30 millimeters of mercury, there is no glaucomatous damage, simple discontinuation of the drug is enough. If it is more than 30 millimeters of mercury with mild to moderate damage, you need to stop the steroid first and then continue with the anti-glaucoma medication for 3 to 6 weeks, then assess the patient and then you can reduce or you can add the medication. If it is more than 20 millimeters of mercury with the maximum medical therapy, and if it is advanced glaucoma, definitely you need a surgical treatment. So I'll show 3 of my cases. This is a first case of 45-year-old female, came with vision of CF 1 meter in left eye, 46 millimeters of mercury of IOP, and she had 3 months history of post-cataract surgery. She is using Aflox-D 4 times daily after 1 week. First week she used to use 6 times, and the next 10 weeks she was on Aflox-D 4 times a day. So the pressure rose to 46 and hazy fundus. Just we had one carbonic anhydrase inhibitor, systemic tablet Dimox OD for 1 week and stopped steroids, and at the end of 2 weeks the pressure is 16 and vision is 6.6, fundus normal. So just discontinuation and a short course of oral steroids is carbonic anhydrase inhibitor is enough. And the second case is a young boy of 8 years we saw in 2017, and vision in right eye 612, left eye 6.9, severe VKC, and the consulted some local ophthalmologist, they gave steroids and they got some relief with the steroids. So the parents brought the medication, on-counter medication, and they are using in between. Finally he developed steroid-induced glaucoma. And right eye pressure 56, left eye 48, and kept them on MMT and asked them to come for follow-up after 2 weeks. But they lost follow-up and they came after 6 months, and they developed severe VKC at that time, and they stopped AGM also after 1 month of using the anti-glaucoma medication. Now the pressure is 64 in right eye, vision came down from 612 to CF half meter, and left eye pressure is 58 and 6.9 is the vision. So right eye total GOA, left eye advanced glaucoma with pale disc. So we kept him on MMT. Already he lost one eye. We did TRAB in left eye in 2018. So this is the disc of the left eye, pale disc, and the vision is maintaining, 6.9 vision is maintaining in left eye since 2018. Now the patient is stable and visual field is also stable. But I feel very sorry for this young boy because he has so much of life. And the third case is a 12-year-old boy. Actually he underwent cataract surgery in 2015 for steroid-induced cataract. And right eye now he is having 32 pressure and left eye 12 pressure. Vision is 618 in right eye and 612. He has severe VKC and fundus is 0.7 in right eye. And with the various combinations of medical therapy, after 3 months the pressure came down to 24. But he developed severe allergy to the AGM. So we planned for TRAB in 2020, December 2020. So TRAB was very well worked for 1 year, and after 1 year he developed another severe episode of VKC where he kept on high dose steroid. Again the pressure rose to 46. After 3 months of medical therapy it was not coming down. Again we did second TRAB, and that second TRAB failed in 3 months, and we did bleb needling. Again that was also failed in 2 months. So finally we opted for implant. So I did implant in Jan 2023. So after implant the pressure is maintaining around 10 since these last 8 months. And the patient, this is the optic disc of the patient, and this is the OCT picture of the patient in 2021, which is maintaining till now, and RNFL is stable and the visual fields are stable. And finally we could save the vision because of the good compliance and proper follow-up, and the patient mother is very helpful for following this patient. And if you find any patient like this, if they need steroids, the newer molecules like loteprednol is very useful in reducing the IOP spikes. And this is the resume we need to follow for all patients who are on steroids when they have steroid responsiveness. So for every 2 weeks you need to follow, and you need to assess the pressure, and if there is any pressure rise you need to start the treatment. And in future maybe anti-steroids may come, but all are in the experimental stage. The take-home message is steroid is always a double-edged sword. Always assess the risk factor before starting steroid treatment in any patient, especially those who are on chronic uveitis where you need recurrent use of steroid, and in VKC patients, and check for responsiveness in those patients for every 2 weeks. And always the prevention is better than cure, so always assess the risk factors, and early detection and proper treatment will always key to the success in these steroid-induced glaucoma patients. Thank you one and all for giving me this opportunity.
Thank you, doctor.
So systemic steroids usually they won't cause a much rise of IOP, sir. Most of the times it's the topical steroids or the intravitreal steroids or the steroids which are applied onto the skin nearer to the local area nearer to the eyelids are systemic steroids. If you use for long term, even the renal patients where they underwent renal surgeries, they used to have steroid induced cataract, but glaucoma we found it's less when compared to the topical and the intravitreal formulations.
Thank you, Dr. Malleswari, for a nice talk with